Hello, everyone, and welcome to the third activity of our special series, Through the Looking Glass, Seeing a Better Future in Crohn's Disease. I'm Dr. Aline Charabaty, Associate Professor of Medicine at Johns Hopkins School of Medicine, Medical Director of the Division of GI and Hepatology, and Clinical Director of the IBD Center at Johns Hopkins Sibley Memorial Hospital in Washington, D.C. I'm joined today by my phenomenal colleague, Dr. Marla Dubinsky. She is Professor of Pediatrics and Medicine and Chief of the Division of Pediatric GI and Nutrition and Co-Director of the Susan and Leonard Feinstein IBD Clinical Center at Mount Sinai Kravis Children's Hospital. Marla, welcome. Thank you for being here.
Thank you for having me today.
If you didn't catch the earlier activities in the series on Treat to Target with Dr. Gnuken and on intestinal ultrasound with Dr. Dollinger in Crohn's disease, you can view them by visiting our Bonham CE site. All these activities are CME certified and jointly provided by PACE and Bonham CE. They are made possible with the support of an educational grant from Lilly. Our disclosures are shown on the screen. Please complete our clear activities survey by clicking the link below this video or by scanning the QR code shown here. Let us know who you are in the polling questions below, and please be sure to complete your evaluation at the end of the session and claim your free CME credits. And of course, follow at Monday Night IBD and at Bonham CE and set your alert notification for more CME certified programs. So today with Dr. Dubinsky, we're going to really dive into our evolving targets in the treatment of Crohn's disease. We had discussed STRIDE 2 targets, but we are looking into the future and looking at what other objective targets will be important to reach, such as transmural healing, maybe histological remission, but also focusing back on the patient and on the symptoms that matter the most to them. And sometimes we underaddress or undervalue, such as bowel urgency. Marla, I want to start by talking with you about the importance or the data that we have regarding achieving transmural healing in Crohn's disease. Does this change the outcome, and does this affect the disease progression in patients with Crohn's disease?
Great. Well, thanks for asking me to talk on this topic. I know that you've already talked about intestinal ultrasound and its role in the clinic. I'm going to take that to the next level and talk about how maybe that will be part of helping us build out the STRIDE 3 guidelines or consensus around the future management of our targets. There's some emerging data that really we're measuring the wrong thing when it comes to understanding, can we modify the disease when it comes to Crohn's disease? We know that we've gone from symptoms to biomarker to endoscopy and maybe histology, which we'll talk about in a moment. But I think for Crohn's disease, really the holy grail is transmural healing. So there was a study that was published in 2019, which looked at 4 different outcomes as it relates to endoscopy or mucosal healing versus transmural healing versus no healing. And just across the board, no matter how you looked at it, the steroid-free remission was superior with transmural over mucosal, even by 20% plus in terms of the delta. Also, clinical relapse, you had almost annihilated the rate of clinical relapse by actually achieving transmural healing. Need for hospitalization was significantly decreased. Most importantly, which is the true disease modification, particularly for Crohn's disease, is need for surgery in individuals who had transmural healing versus 10% with endo, which is still great outcome compared to no healing, which was a third plus of the patients required surgery. But I think you're understanding the idea that if Crohn's is a transmural disease, and we know that muscle hypertrophy and collagen deposition in the submucosa leads to stenosing or fibrostenotic and or stricture in Crohn's disease, I think it makes sense for us to say, well, maybe the mucosal layer alone is not reflective of the 4 layers of the bowel wall of Crohn's disease.
It makes sense that transmural healing will lead to better outcomes in our patient with Crohn's disease. Marla, do we have the therapies? Do we have the data on what therapies can help us achieve transmural healing? And are we ready to start adjusting therapy or optimizing therapy to achieve this treatment goal?
when you think about the idea that if we may not be able to get there in all of our drug therapies, I think even the next layer of understanding is what therapies can we get there with? And do all our therapies achieve transmural and or endoscopic healing, let alone, because now there's this emerging fascination around disease location when it comes to Crohn's disease. And there are differential healing patterns, both endoscopically and now at ACG, we presented transmurally. There are different healing properties to our different therapies. When you look back, when you're thinking about using ultrasound as a treat to target, because I know there was a discussion around it, can we use it as a treat to target? Meaning, is there enough of a responsive change early in induction to actually merit that you would use that to say, hey, if we don't get that minimum change, just like we do with an SESCD in a clinical trial, if we don't get that minimal change, should we optimize based on that ultrasound finding? And actually, there's some emerging evidence that post-induction, if you don't have a 20% delta in your ultrasound change as a response, you need to optimize, because that is predictive that you will not achieve a treat to target endoscopy when you do for mucosal. So there is even emerging also evidence that you can use ultrasound to optimize. And what we just presented at ACG, that actually, to be fair, the therapies that have the most transmural remission post-induction won't be surprising to you, Aline. It is TNF, particularly for ileal disease, and upadacitinib. So infliximab more particularly, even over adalimumab. So it shouldn't surprise you that going back to 1998, we actually have a therapy that not just actually makes people feel better. Yay, we got mucosal healing, and the Liberty study 25 years later says, yes, infliximab does actually have fantastic endoscopic or mucosal healing, but now we're seeing it also as one of the superior therapies for transmural healing early.
Overall, very exciting to recognize that we're moving the needle in terms of our treatment targets and goals for Crohn's disease, and that achieving transmural healing can decrease the risk of disease progression and complication. Now, I want to shift gear and talk about histological healing. We have talked a lot about histological healing in ulcerative colitis as a potential target that could decrease the risk of disease complication in UC. Is histological healing also a potential target in Crohn's disease? And do we know if it can modify disease course in Crohn's disease?
Yeah, it's interesting just to bring up ACG, since we're fresh off ACG and we love bringing literally stuff from the podium to practice. So this is a fantastic opportunity. So it was interesting in speaking about, does location matter? Similarly, the question on does histology matter in Crohn's disease? What we know is that there are individuals, lots of them, who have mucosal healing and still have histologic inflammation. About a quarter of individuals in some of the studies we have shown that even though you may have an SESCD of 0 or ulcer-free remission, you do have crypt abscesses or you may have neutrophils. Now, one of the problem is, how do you define it? Every trial looks at it differently, so that's been sort of somewhat difficult to put in print as to what we're really trying to get at. The patchiness, many of us are not trying to actually biopsy a deep ulceration. So, where are we measuring it? What is the real advantage of histology? I know in UC, we put for STRIDE that maybe STRIDE 3 would be histologic healing or remission for UC, but we didn't quite put that as our North Star for Crohn's disease, I think because of some of the issues we just talked about. And I stood up and Barnes presented on IL-23, specifically mirikizumab, looking at location and talking about histology and HEMI scores. So the histo-endo improvement score in Crohn's disease using mirikizumab specifically. So I did get up and I think made the case, and I'll make the case to today, that goes back to what we just talked about, is I'm not sure histologic is actually what we should be measuring to really change the natural history of Crohn's disease. So I do feel that right now we don't have enough evidence for sure to put a strike 3 stamp in the ground around histo and Crohn's disease. And I would venture to say that histology is more of a UC target, in my opinion, right now, because there is some emerging evidence from clinical trials that HEMI is definitively achievable. And now we have to know, does it change the natural history? One of the things I always struggle with, and when it comes to STRIDE, if you look at the historical, because I was there from 2015 and then moving to the STRIDE 2 and then hopefully driving STRIDE 3, is the idea that even in 15, we didn't have enough evidence to say that for calpro and CRP, you should be using it to actually optimize therapy. You don't need a scope. We said, oh, it's a surrogate to go scope. What did we know? It was based on the idea that there was not enough literature to support that. Then we moved to 21. We're like, wow, clinical trials, calpro, CRP, a lot of real world. And so unless we have enough data to support that there is an indication to optimize based on that target, because it will change the natural history, that is when it will become a STRIDE 3 target, because we do a systematic review and then we do the consensus. So I would venture to tell you that I view histo healing in CD very far right now from where we can put a STRIDE 3 sort of stamp of approval. So that's why I want everyone to understand that there's more data that we can work off of probably in UC than we can in Crohn's right now.
Marla, I want to switch gears with you and move from potentially future objective targets in our treatment for Crohn's disease and bring back what the patient goals are in terms of what they are expecting from the treatment, and mainly addressing the symptoms that are affecting their quality of life, the symptoms that are keeping them isolated, that are affecting their psychosocial health and their financial wealth. You have been a big champion of discussing bowel urgency in our clinic, in our interaction with the patient. Talk to us about bowel urgency in the context of Crohn's disease.
We all understood or have known, and guidelines have even discussed it, to ask UC patients about urgency. That's why I need to set it up, because Crohn's disease and urgency was not something we were putting together unless someone had colonic type Crohn's, maybe rectal Crohn's. We sort of just really relied on the colon to be the driver of urgency. And in UC, and particularly, I would have to say that our colleagues at Lilly really did an amazing job of bringing it out to people's attention, for people to have conversations and ask their patient about urgency, but go beyond, do you have urgency? Yes, no, because that's not where the conversation needs to end. It's how severe is your urgency, literally using a numeric rating scale of 0 to 10, with 10 being worst possible urgency and 0 being no urgency. So this 11-point scale is really important for the severity, because one of the things we know is that until you ask a patient, and unless it is part of your routine drop down in your EHR or your routine discussion on rectal bleeding, frequency, abdominal pain, urgency, yes, no, how severe, do you have accidents, have you had an accident? And most importantly, which I always say gives me chills to the idea that I am now asking my patients because of the CONFIDE survey, do you need to wear a diaper or protective garment? And the fact that almost 50% of our patients answer yes within at least once a week, it really just sort of tells you how much isolation and shame, which is what you just mentioned, the idea that you isolate and suffer in silence. And a lot of our patients don't want to bring it up because they think they're the only ones. My doctor's not asking me, and he always asks me about blood and pain and diarrhea. He's never asked me, or she's never asked me about urgency. I must be the only one. I'm too embarrassed to bring it up. And at a symposium we actually did at ACG, again, there was a question Q&A that came in. My patients don't report urgency. And I really had to take a moment and just say, are you asking? Because if you don't ask, but I promise you, if you ask, that even a Crohn's disease patient, and that's sort of the lead into, in Crohn's disease, we saw the same amount of urgency reported in the CONFIDE survey, which is an anonymous survey sent to US, Europe, and Japan, both patients and providers, to talk about what are the most burdensome symptoms you've experienced. Let's say we've asked it in the last month, and I'll talk for that in about a minute, and that in Crohn's disease patients, bowel urgency is the second most common symptom experienced by patients in the last month. That's in a Crohn's patient without rectal inflammation, even in the absence of perianal disease. When we asked them about the frequency of bowel urgency in the last 3 months, most of them reported that more than once a week, almost 20% reported daily. And so what are we missing here that we're not really appreciating the impact of bowel urgency, even in Crohn's disease? So we don't even include it in our PRO or a clinical trial. But you will see that mirikizumab Crohn's disease trial, to be fair, they started the conversation with bowel urgency remission and bowel urgency improvement or response in the UC. And you will see that similarly in MIRI for Crohn's disease as a key outcome, which is incredible because we have never asked that as part of a Crohn's disease trial. And so I really give them credit for actually saying this is important, not just for UC, and opening our eyes also in Crohn's disease. And we know that when we talk about clinician perspective in Crohn's disease, most clinicians aren't proactively discussing urgency, even with Crohn's disease, let alone with ulcerative colitis, but for sure in Crohn's disease, because we are super focused on diarrhea, stool frequency, blood, abdominal pain, and it is really missed. And I think also us not understanding what we think is going to drive our treatment decision. Patients are like, I'm not getting out of the house. I'm not engaging in my social activities. I am isolating because of bowel urgency and bowel-related accidents. And for us as clinicians, it is low down on the list as to what is impactful to our patients. And I think if today is just opening up the dialogue for Crohn's disease as well, I'm super happy and really grateful for the opportunity to at least tell people about this passionate topic of all of ours, which is what is impacting our patients the most. And it also tells us that there's a different mechanism for urgency, perhaps in Crohn's disease. And this is where I go down this concept of the mind-body or the brain-gut, and gut meaning pelvic floor for us is so critical and really is something we need to start digging into, and really what is happening to our patients who are suffering in silence.
Thank you. That was very powerful. And kudos to clinician and scientist advocate like you and to patient advocate for really bringing this at the forefront. So I think it's upon us as physicians to really create that safe space for patients so they can feel comfortable talking about bowel urgency and other issues that are important to them, anywhere from their sexual health to financial health to psychosocial well-being. And all these things end up being really related. So I'm going to close it here because this was absolutely powerful. So thank you again, Marla, for this very insightful review of what to expect next in terms of our target, anywhere from objective targets such as transmural healing, maybe histological healing, not there yet, but transmural healing has the potential to change disease course. And the issue now is to have the data, recognize which therapy allows us to achieve transmural healing and how we can optimize therapy to achieve this potentially new treatment target. Patient symptoms, very important to address them, to really allow patients to talk to us about what's important for them, what is affecting their quality of life, and how the therapies that we have available can address these patient concerns. And finally, again, as clinician, we should be the best advocate for our patient, not just treating them, but really advocating for them and amplifying their voice in order to improve their disease prognosis, but also their quality of life and allow them to live their life to their fullest. So thank you, everyone, for joining us. I think this was a very meaningful conversation, and only Marla could bring the objective and the passion and really putting it back and centering around the patient and what's important for the patient. Please make sure to claim your CME credit by completing the pulse survey and evaluation form in the links below or by scanning the QR code shown on the screen. Thank you for being with us, and we'll see you soon for another Monday Night IBD and Bonum CE activity.